Walter came into my office on a Wednesday afternoon and told me he had given up his car keys. He was 70 years old, retired engineer, a man who had built bridges for a living, precise, methodical, composed, not a man given to impulsive decisions or unnecessary drama. He slid the keys across my desk like he was handing over something that had already cost him more than he could afford. He said, "I nearly hit a child on a bicycle last Tuesday. She came out of nowhere. I braked in time, but I was not fast enough. My reaction was not what it should have been. I sat in that car in the middle of the street for 5 minutes before I could keep driving. And when I got home, I took the keys off the hook and I put them on the counter and I told my wife I was done." His wife had cried. His daughter had coped relief. Walter had sat with the weight of what it meant for a man of his independence to surrender the one thing that most concretely represented his ability to move through the world on his own terms. He was not there to ask me whether he had made the right decision. He already knew he had. He was there because he wanted to know why. Why at 70, with no history of neurological disease, no history of stroke, no major medical events beyond well-managed high blood pressure and slightly elevated cholesterol, his reaction time had deteriorated to the point where a child on a bicycle had come that close. He wanted to know what was happening inside his brain. I ordered a comprehensive panel, blood work, a detailed cognitive assessment, and because his history and his presentation gave me a specific suspicion I wanted to rule in or rule out, I ordered a brain MRI. I did not tell Walter what I was looking for. I did not want to alarm him before I had something to tell him. 2 weeks later, when the results came back, I called him and asked him to come in. He sat across from me again, same composure, same steady hands, same eyes that had spent 40 years looking at engineering drawings and trusting what they measured. I showed him the MRI. Neither of us spoke for a long moment, because what the scan showed was not what either of us had expected. It was not a tumor, it was not a stroke, it was not early Alzheimer's pathology, it was something more common, more treatable, and more invisible than any of those things. Something that had been quietly dismantling his cognitive function for years while he slept, worked, lived his life, and had no idea. Something that now that we had found it, we could address. And something that 6 weeks after we began treatment had his reaction time, his processing speed, and his cognitive test scores moving in a direction that made both of us sit back in our chairs with something that felt cautiously like relief. Who is talking to you today? My name is Dr. James Harlow. I have been practicing internal medicine for 10 years, specializing in cardiovascular and metabolic health in adults over 50. I want to begin with something I tell my patients regularly, and that I believe deeply after a decade of watching what happens inside aging bodies. Cognitive decline is not inevitable. It is not simply what happens when you get old. It is not a sentence that is handed to you on your 70th birthday and cannot be appealed. For a significant proportion of adults over 60 who are experiencing memory problems, slowed thinking, difficulty concentrating, or the kind of reaction time deterioration that Walter experienced, the cause is not irreversible neurodegeneration. It is a correctable physiological problem that has been operating undetected because nobody asked the right questions or ordered the right tests. Walter's case is not unique. I have seen versions of it more times than I can count. A sharp, functional, independent adult who begins to notice that their mind is not performing the way it used to, who dismisses it as aging, who adjusts their life around the limitation rather than investigating its cause, who, when the right investigation is finally done, discovers that what they assumed was the inevitable erosion of time was actually something specific, something measurable, and something that responds to treatment. What I am going to share in this video is information that I believe every adult over 60 and every family member of an adult over 60 needs to have, because the window for intervention in the conditions I am about to describe is not infinite. The earlier they are identified and addressed, the better the outcomes, and the most common reason they are not identified early is not medical complexity. It is simply that the patient, and sometimes the physician, assumed that what they were experiencing was normal. It is not always normal. Sometimes it is fixable. Walter's story is proof. Walter's story, what was really happening? Let me take you deeper into Walter's history, because the pattern of his decline, when you look at it with the right frame, had been visible for years before the incident with the bicycle. Walter had been sleeping poorly for approximately 4 years. He would tell you he slept fine, 7 hours, sometimes 7.5. But his wife would tell you a different story. She had moved to the guest bedroom 18 months earlier because his snoring had become intolerable, not just loud, but interrupted, punctuated by pauses that she described as frightening, moments of silence that went on long enough that she would hold her breath waiting for the next sound. Walter did not remember any of this. He did not remember the pauses. He did not remember the partial arousals that were interrupting his sleep architecture. Dozens of times every hour, he woke each morning and said he had slept fine because he had no memory of the night's events. But the evidence was there in the mornings if you looked. He was always tired, not dramatically tired, functionally tired, the kind of tired that sits behind your eyes and slows the gears. He had stopped reading at night because he could not maintain concentration past the first few pages. He had started drinking a second cup of coffee in the afternoons. He had quietly stopped taking on complex home projects, the kind that required sustained planning and precise execution, telling himself he simply did not have the interest anymore. He had stopped having the interest. That part was true. What he did not know was why. His blood pressure had been creeping upward for 3 years, despite medication adjustments. His fasting blood sugar had crossed into pre-diabetic range 18 months ago. His cardiologist had mentioned, almost as an aside, that his heart rate variability was low, a marker of autonomic nervous system stress. None of these data points had been connected to each other or to his cognitive performance. They were all the same signal. They were all coming from the same source. When Walter's MRI came back, it showed white matter hyperintensities, small areas of abnormal signal in the deep white matter of the brain, not extensive, not catastrophic, but present in a pattern and distribution that told me exactly what had been causing them, and exactly how long the process had likely been underway. White matter hyperintensities are the brain's visible record of repeated vascular insults, small episodes of reduced oxygen and blood flow to the deep brain tissue that leave permanent marks on the imaging. They are associated with cognitive slowing, processing speed reduction, executive function impairment, and reaction time deterioration. They are strongly associated with two conditions that Walter had been living with untreated for years: uncontrolled nighttime blood pressure surging and obstructive sleep apnea. Walter had both. His polysomnography, the overnight sleep study I ordered alongside the MRI, confirmed severe obstructive sleep apnea, 41 apnea events per hour, blood oxygen dropping below 85% multiple times per night. His brain had been living in a state of intermittent oxygen deprivation and vascular stress every single night for years, and the MRI was showing us the accumulated damage of all those nights, written permanently into his white matter. The near miss with the bicycle had not been a sudden deterioration. It had been the visible surface of years of invisible erosion, the final millimeter of a bridge that had been quietly corroding for a long time. The science your doctor never explained. Number 1. White matter hyperintensities. The brain's hidden damage record. The brain is composed of two broad categories of tissue: grey matter, which contains the neuron cell bodies, the processing centers, and white matter, which contains the axons, the long projections that connect different brain regions and allow them to communicate with each other. White matter gets its name from the myelin that surrounds these axonal projections, giving the tissue its characteristic pale color on imaging. White matter is the brain's communication infrastructure. It is the network of cables that allows one region of the brain to send information to another. When white matter is damaged, communication between brain regions slows or fails. The brain does not lose processing centers, it loses the high-speed connections between them. White matter hyperintensities appear on MRI as small bright spots in the white matter regions of the brain. They represent areas where repeated vascular insufficiency, inadequate blood and oxygen delivery to the deep brain tissue, has caused damage to the axons and their surrounding myelin. The tissue does not die completely, but it is injured, scarred, and functionally impaired. The consequences of white matter hyperintensities depend on their location, number, and extent. Small numbers of hyperintensities in older adults are common and may produce subtle effects. Larger burdens of white matter disease produce measurable impairments in processing speed, attention, working memory, and executive function, the complex cognitive abilities required for tasks like driving, planning, problem-solving, and managing multiple streams of information simultaneously. Reaction time, the specific ability that failed Walter at the moment that mattered, is one of the cognitive functions most consistently impaired by white matter hyperintensity burden. Critically, white matter hyperintensities accumulate progressively. Each vascular insult adds to the burden. Each night of untreated sleep apnea, each night of uncontrolled blood pressure surging, each sustained period of cerebrovascular stress contributes another small injury to the deep white matter. The damage is not reversible, in the sense that existing lesions do not disappear, but the progression, the rate at which new lesions develop, can be dramatically slowed or halted when the underlying causes are identified and treated. That is why Walter's story matters. Not because his existing white matter damage disappeared, but because when we treated what was causing it, the progression stopped. And when the progression stopped, his brain had the opportunity to compensate and to recover function that the advancing damage had been suppressing. Number 2. Sleep apnea and the brain. The oxygen deprivation nobody sees. We discussed sleep apnea in another video in this series in the context of cardiovascular disease, but its effects on the brain deserve their own detailed attention because the mechanisms are distinct and because the cognitive consequences are among the most serious and least recognized aspects of this condition in older adults. The brain's dependence on oxygen is absolute and immediate. It has no oxygen reserve. When oxygen delivery drops, brain function begins to deteriorate within seconds. In sleep apnea, blood oxygen drops repeatedly during every hour of sleep, sometimes to levels that, if they occurred in a waking patient, would constitute a medical emergency. The hippocampus, the brain's primary structure for memory formation and consolidation, is among the regions most sensitive to intermittent hypoxia. Studies using high-resolution MRI have found measurable reductions in hippocampal volume in adults with untreated sleep apnea compared to matched controls. Volume reduction in the hippocampus correlates directly with memory impairment scores in clinical testing. The prefrontal cortex, responsible for executive function, planning, impulse control, and the complex attentional processes required for driving, shows similar vulnerability. Functional MRI studies have demonstrated reduced activation and connectivity in prefrontal networks in adults with untreated sleep apnea, producing exactly the kind of slowed, imprecise cognitive performance that Walter was experiencing. The white matter hyperintensities seen on Walter's MRI are a direct consequence of repeated nighttime hypoxia and the associated vascular stress. Each time his oxygen dropped and his blood pressure surged during an apnea event, the small blood vessels supplying the deep white matter were subjected to stress that over time caused the small vascular injuries visible on imaging. A major meta-analysis published in the journal Sleep Medicine Reviews found that adults with untreated obstructive sleep apnea show impairments in attention, memory, executive function, and processing speed across multiple validated cognitive tests. Crucially, the same meta-analysis found that CPAP therapy, when used consistently, produced measurable improvements in these cognitive domains in a significant proportion of treated patients. The brain, even with established white matter changes, retains a degree of plasticity and compensatory capacity when the ongoing insult driving the damage is removed. Walter's brain had been living in oxygen debt every night for years. When we gave it oxygen, consistently, night after night, through CPAP therapy, it began to recover function it had been suppressing as a consequence of ongoing stress. Number 3. Nocturnal hypertension and the small vessel disease nobody checks for. Walter's blood pressure had been rising for 3 years. His cardiologist had adjusted his medication twice. What neither his cardiologist nor his internist had ever done was measure his blood pressure during sleep. Daytime blood pressure readings, taken in a clinical setting, provide a snapshot of blood pressure during waking hours. They do not tell you what happens during the night. And for adults with sleep apnea and treatment-resistant hypertension, nighttime blood pressure is frequently far more elevated than daytime readings suggest. During obstructive sleep apnea, each apnea event produces an acute blood pressure surge, sometimes 20 to 40 millimeters of mercury in a matter of seconds, as the sympathetic nervous system fires to restore airway tone. In a patient with 40 apnea events per hour and 7 hours of sleep, this means hundreds of blood pressure surges every night. The cardiovascular and cerebrovascular consequences of this pattern are distinct from and additive to the consequences of sustained daytime hypertension. The small blood vessels that supply the deep white matter of the brain are particularly vulnerable to this pattern of repeated pressure surging. Unlike the larger arteries, which have muscular walls capable of accommodating pressure fluctuations, the small penetrating arteries and arterioles of the deep brain have thin, relatively inflexible walls. Repeated pressure surges damage these walls over time, a process called hypertensive arteriolosclerosis. The damaged vessels narrow, blood flow to the white matter they supply diminishes, small infarcts and areas of ischemic damage develop. These are the white matter hyperintensities on Walter's MRI. 24-hour ambulatory blood pressure monitoring, a simple, wearable device that takes blood pressure readings throughout the day and night, would have revealed Walter's nocturnal blood pressure pattern years before his MRI showed the consequences. This test is widely available, inexpensive, and covered by insurance when indicated. It is, in my opinion, one of the most underutilized tools in the management of hypertension in older adults. When we started Walter on CPAP therapy, his overnight blood pressure surging stopped. Within 4 weeks, his daytime blood pressure had dropped sufficiently that we were able to reduce his medication. The blood pressure his medication had been struggling to control for 3 years had been driven in large part by a condition his medication could not touch. Number 4. The cerebrovascular reserve and why it matters after 70. Here is a concept that most patients have never heard of, but that I believe every adult over 60 needs to understand. Cerebrovascular reserve refers to the brain's ability to increase blood flow in response to increased demand. When you engage in complex thinking, solve a difficult problem, react quickly to an unexpected situation, your brain requires more blood and oxygen than it does at rest. In young healthy adults with flexible, responsive blood vessels, cerebral blood flow increases rapidly and substantially in response to this demand. The brain has abundant reserve capacity. Cognitive demand is met without strain. In adults over 60 with white matter disease, hypertension, and vascular risk factors, cerebrovascular reserve is reduced. The small blood vessels of the brain have become stiffer, narrower, and less responsive. Blood flow increases more slowly and less substantially in response to cognitive demand. The brain still attempts to perform the required task, but it is doing so while reaching for a blood supply that cannot keep pace. The result is exactly what Walter described, not a complete cognitive failure, a slowing, a hesitation, a fraction of a second lost in the moment when the bicycle appeared, and his brain needed maximum speed to respond. That fraction of a second is the cerebrovascular reserve deficit, made visible in the real world. Improving cerebrovascular reserve in adults over 60 is an active area of research, but the interventions with the strongest current evidence are straightforward: treating sleep apnea to eliminate nocturnal hypoxia and blood pressure surging, controlling blood pressure, including nocturnal blood pressure, to reduce ongoing vascular injury, regular aerobic exercise, which promotes vascular flexibility and increases cerebral blood flow at rest, dietary patterns that reduce vascular inflammation, particularly the Mediterranean dietary approach, and managing metabolic risk factors, blood sugar, cholesterol, inflammation, that accelerates cerebrovascular aging. Walter had been given advice about blood pressure and exercise for years. He had followed it imperfectly. What he had never been given was the specific context that would have motivated complete adherence, the knowledge that every point of blood pressure reduction, every night of adequate oxygenated sleep, every morning walk was directly protecting the small vessels inside his brain from the damage that was writing itself onto his MRI. Information changes behavior. Walter had not had the information. Number 5. Processing speed, reaction time, and the driving test nobody takes. Driving is, from a neurological standpoint, one of the most cognitively demanding tasks most adults perform routinely. It requires sustained attention, divided attention across multiple streams of information, spatial processing, rapid decision-making, and reaction time responses measured in fractions of a second. These are precisely the cognitive abilities most vulnerable to white matter disease, sleep deprivation, and cerebrovascular insufficiency, and they are among the first abilities to show measurable deterioration as brain health declines, often years before more dramatic symptoms like memory failure or disorientation become apparent. Walter's near miss with the bicycle was a cognitive stress test that the road administered to him unexpectedly. His brain, already operating with compromised white matter and reduced cerebrovascular reserve after years of untreated sleep apnea and nocturnal hypertension, did not have the processing speed reserve to respond at full speed when the situation demanded it. He had been passing other cognitive tests that did not place the same instantaneous demand on his brain. His conversations were normal, his memory for recent events was adequate, his reasoning was intact, but reaction time, the product of rapid sensory processing, motor command generation, and physical execution, requires peak white matter integrity and cerebrovascular reserve. It has almost no capacity to compensate through alternative cognitive strategies. You cannot react faster by trying harder in the moment. You either have the neural infrastructure or you do not. Walter had been losing that infrastructure one night at a time for 4 years. The studies on driving and sleep apnea are unambiguous and underpublicized. Adults with untreated obstructive sleep apnea have 2 to 3 times the motor vehicle accident rate of matched adults without sleep apnea. They perform significantly worse on driving simulation tests measuring reaction time and hazard detection. The impairment from untreated moderate to severe sleep apnea in driving relevant cognitive tasks is comparable to the impairment from a blood alcohol level above the legal limit in many jurisdictions. Walter was every morning when he got behind the wheel cognitively compromised in a way that had nothing to do with alcohol, medication, or aging in any inevitable sense. He was compromised by a treatable medical condition that nobody had identified. Number 6. The metabolic connection, prediabetes, insulin resistance, and brain fog. Walter's fasting blood sugar had crossed into pre-diabetic range 18 months before his MRI. This finding had been noted in his chart and addressed with dietary counseling. It had not been connected to his cognitive symptoms. It should have been. The connection between insulin resistance and cognitive function is one of the most robust and most underappreciated relationships in metabolic medicine. The brain is one of the most metabolically active organs in the body, and it is exquisitely sensitive to disruptions in glucose metabolism. Neurons rely on a steady, well-regulated supply of glucose for their energy needs. When insulin signaling becomes impaired, as it does in prediabetes and type 2 diabetes, glucose delivery to neurons becomes dysregulated. Brain cells that cannot efficiently use glucose for energy begin to function suboptimally. The hippocampus and prefrontal cortex, the same regions most affected by sleep apnea-related hypoxia, are also among the brain regions most sensitive to insulin resistance. Studies examining brain function in adults with prediabetes compared to those with normal glucose metabolism consistently find impairments in memory, processing speed, and executive function even before the pre-diabetic criteria are met. The relationship is dose-dependent. The more impaired the insulin signaling, the worse the cognitive performance. Insulin resistance also promotes vascular inflammation, increases oxidative stress in cerebral blood vessels, and accelerates the small vessel disease that produces white matter hyperintensities. Walter's prediabetes was not a separate issue from his brain scan findings. It was a contributing factor to the same pathological process. When we addressed his sleep apnea with CPAP, which independently improves insulin sensitivity through its effects on cortisol and sympathetic nervous system activity, his morning fasting glucose began to improve within 6 weeks without any change to his diet. His brain was getting better metabolic fuel, at the same time it was getting better oxygen. The two interventions compounded each other. Number 7. What recovery looks like and what it takes. I want to be honest with you about what recovery from white matter disease and chronic cerebrovascular insufficiency looks like, because unrealistic expectations serve no one. Existing white matter hyperintensities on an MRI do not disappear when treatment begins. The scars remain. What changes is the rate of new injury. When the underlying causes, sleep apnea, nocturnal hypertension, insulin resistance, vascular inflammation, are identified and treated, the brain's ongoing vascular stress is reduced. New lesion formation slows or stops. The brain, no longer under constant attack, can begin to allocate its resources toward function rather than defense. Neuroplasticity, the brain's ability to rewire, compensate, and build new connections, does not end at 70. It is reduced compared to younger brains, but it is not absent. When the factors driving dysfunction are removed, the brain in many cases demonstrates a capacity for functional recovery that exceeds what the structural imaging would predict. Processing speed improves, attention sharpens, memory consolidation becomes more efficient, reaction time, measurable on validated cognitive assessments, improves in a significant proportion of patients who receive adequate treatment for the underlying conditions. Walter's 6-week follow-up cognitive assessment showed measurable improvement in processing speed, sustained attention, and working memory compared to his baseline. His reaction time on the validated assessment tool we used improved by a margin that placed him back within normal range for his age group. He did not return to driving immediately. He wanted more time. He wanted to be certain, not just statistically reassured. At 3 months, after a formal driving evaluation administered by an occupational therapist specializing in driver rehabilitation, a resource most people do not know exists, Walter passed. He drove home from that evaluation himself. His wife was standing in the driveway when he pulled in. He said she cried. He said he might have as well. What you should do right now, if you are over 60 and you have noticed slowing in your thinking, difficulty concentrating, declining reaction time, or the gradual withdrawal from activities that require sustained cognitive effort, do not accept this as the inevitable cost of aging before you have investigated its cause. Here is what needs to happen. Ask your doctor for a sleep study. If you snore, if your partner reports breathing pauses during your sleep, if you wake unrefreshed, if you are consistently fatigued despite adequate sleep hours, obstructive sleep apnea is a likely contributor to whatever cognitive changes you are experiencing. It is treatable. The cognitive benefits of treatment are real and documented. Ask for 24-hour ambulatory blood pressure monitoring, particularly if your blood pressure has been difficult to control on medication, or if you have never had your nighttime blood pressure specifically measured. Nocturnal hypertension is a major driver of cerebrovascular disease and white matter damage in older adults. You cannot treat what you have not measured. Ask about cognitive testing. A formal baseline cognitive assessment, administered by a neuropsychologist or through a validated clinical protocol, gives you and your physician objective data about where your cognitive function currently stands and which domains, if any, show impairment. This baseline allows meaningful tracking over time and can help distinguish normal aging from treatable pathology. Ask about a brain MRI if you have multiple vascular risk factors and cognitive symptoms. Not every patient needs this immediately, but if you have hypertension, prediabetes or diabetes, a history of poor sleep, and cognitive symptoms, the imaging may provide critical information about what is already happening in your white matter and how urgently intervention is needed. Get your fasting glucose and hemoglobin A1C tested. If you are in pre-diabetic range, treat it aggressively, not passively. Dietary change, regular aerobic exercise, and in some cases medication can reverse prediabetes in adults over 60 and have measurable effects on cognitive trajectory. Exercise consistently. Aerobic exercise is the single intervention with the broadest and most robust evidence for preserving and improving cerebrovascular health in older adults. It promotes vascular flexibility, increases cerebral blood flow, stimulates the production of brain-derived neurotrophic factor, BDNF, a protein essential for neuroplasticity and new synapse formation, and reduces the inflammatory markers that accelerate vascular aging. 30 minutes of moderate intensity aerobic exercise, 5 days per week. This is not optional for anyone who wants to protect their brain. Consider a Mediterranean-style dietary pattern. The evidence supporting Mediterranean diet for cerebrovascular health and cognitive preservation is among the strongest in nutritional epidemiology. Olive oil, fatty fish, vegetables, legumes, nuts, and whole grains as the dietary foundation, processed food, refined carbohydrates, and seed oils minimized. This is the nutritional environment in which the aging cerebrovascular system performs best. Final message and call to action. Walter gave up his car keys because a child on a bicycle came too close. He was embarrassed. He was grieving. He was afraid of what it meant. What it meant was that his brain had been telling him something for years. In the fatigue, in the lost interest, in the second cup of coffee, in the projects he no longer started, and the near miss was the moment the message became impossible to dismiss. When we found the cause, we could address it. When we addressed it, his brain began to recover. When his brain recovered, he drove himself home from a rehabilitation evaluation 3 months later, while his wife stood in the driveway, and both of them cried. Walter did not lose those 3 months fighting something inevitable. He spent them recovering from something that should have been found years earlier. That is what I want for you. Here is what I want you to do today. Think about whether your thinking is what it was 5 years ago. Think about whether you have quietly adjusted your life to accommodate a mind that is not performing the way you know it can. Think about whether the people in your life have noticed something you have been explaining away. If any of those answers gives you pause, make an appointment this week, not to panic, to investigate, to find out whether what you are experiencing is inevitable or treatable. Most of the time, when we look carefully, we find things we can address. Then watch the next video on this channel, where I walk through the complete brain health protocol for adults over 60, the specific tests, the specific interventions, and the specific daily practices that protect cognitive function and cerebrovascular health through the decades ahead. And share this video with someone who needs to hear it. Share it with someone who has been sleeping poorly for years and dismissing it. Share it with someone whose reaction time is not what it used to be. Share it with someone who has been quietly stepping back from the life they built because their brain is not keeping pace. It does not always have to stay that way. Walter is proof. I am Dr. James Harlow. I will see you in the next one.